Just going to say a quick hello to everyone and welcome. We're thrilled to have you join us today for the first part of our two-part webinar series titled Psychedelic-Assisted Therapy for PTSD, Exploring the Science and Clinical Applications. My name is Dr. Melissa Zielinski. I'm an associate professor at the University of Arkansas for Medical Sciences and chair of ISTSS's Education Production Subcommittee. I'll just be briefly introducing our speaker today. Before we dive in, I just wanted to cover a few housekeeping items. So this session will be about 45 minutes long. And we wanted to highlight, while this first part of the series is intended to be a foundational primer and will therefore not be taking live Q&A today, please feel free to drop your questions into the Q&A feature in Zoom. We're going to be using the questions that come in to inform the part 2 panel discussion that will come up later this month. With that said, it's now my pleasure to introduce our speaker, Dr. Leslie Morland, who will be presenting Psychedelic-Assisted Therapy for PTSD, the State of the Science. Dr. Morland is a clinical psychologist and senior researcher at the VA National Center for PTSD, Women's Health Science Division, and a professor of psychiatry in the School of Medicine at the University of California, San Diego. Dr. Morland served as the Chief Outpatient Access and Director of Telemental Health for the VA San Diego healthcare system for the past 9 years. Prior to this role, she was Deputy Director at the National Center for PTSD Pacific Island Division. As a researcher at NCPTSD over the past 25 years, Dr. Morland has focused on enhancing our knowledge of how to best deliver PTSD care for veterans and on informing policy on a national level on improving access, quality, and efficacy of PTSD care. Specifically, Dr. Morland has executed multiple large federally funded trials focused on evaluating and disseminating the innovative use of technology to increase access and the uptake of evidence-based psychotherapies for PTSD. Dr. Morland's more recent research focuses on examining efficacy with the use of medications such as oxytocin and MDMA to potentiate evidence-based PTSD treatments, like cognitive behavioral conjoint therapy for PTSD and prolonged exposure. Dr. Morland provides research, collaboration, consultation, and mentorship on multiple research projects and national initiatives and strategy planning. She is known as a leader and innovator in the field of PTSD treatment, prioritizing equity and access to evidence-based care across diverse populations. Her research has resulted in over 100 peer-reviewed publications, chapters, and invited presentations. So with that said, we are just thrilled to have Dr. Morland with us today, and I'm going to turn it over to her to start the presentation.
Thank you for the introduction. And so I'm going to talk today about psychedelic-assisted therapy for PTSD. And I will, again, this is a little bit of an overview, a primer for the webinar that's going to happen in 2 weeks, which is going to be a panel with Drs. Rothbaum, Wagner, and myself. So we'll be kind of recording any questions and certainly we'll address them in a couple of weeks. A disclaimer, I definitely am speaking on behalf of myself, not on behalf of the US government or University of California, San Diego. And I want to certainly thank my colleagues who have helped with some of the slides, Drs. Rothbaum and Dimitri and Katya. I wanted to start with a couple of quotes from participants who recently completed trials, just to kind of set the framework for the potential of how powerful psychedelic-assisted therapy can be. These are 2 combat veterans with PTSD. One said, "I did more therapy in that 6-hour period than I've done in my whole life." And the other one said, "I'm so grateful to participate in this study. It was mind-blowing, and I learned more in 3 months than I had learned in my whole life." So just really wanted to kind of start with some statements that were reported to us following some participation and work here. So as was stated, this is a 2-part series. I have kind of a lot to cover, but I'm going to try to just zip through it in a way that's really clear and lays the ground for any questions that might want to be addressed in the next couple of weeks for the second webinar. I'm going to talk about why now is a good time to be thinking about innovations with PTSD, why psychedelics, what is psychedelic-assisted therapy, what do we know about psychedelic-assisted therapy for PTSD, and on the back end, present a couple of new models that are underway. As many of you know, I'm going to talk a little bit about trauma and PTSD. I will kind of go through this part quickly since I'm assuming most of you have all this information, but I do want to set the framework for why now. As we know, trauma is more common than we would like. Worldwide, about 70% of people experience a traumatic event. We do know there's pockets of populations that are more vulnerable. Certainly our veterans and our military are going to be more vulnerable, as well as underrepresented groups are often more vulnerable and will more likely than not experience more trauma. We know PTSD can be debilitating. It can have effects on the individual, their social, cognitive, emotional functioning. Prevalence rate's about 7% for lifetime PTSD. But when we look at our military and our veteran populations, specifically the post 9/11 conflict, we find that that rate jumps up to about 23% of our post 9/11 veterans are struggling with PTSD today. And that's important for a lot of reasons, but it bears a heavy burden on the individuals, the families, and society at large. The military and veteran population suffering from PTSD account for about 42 billion in economic costs annually, which can be attributed to PTSD-related loss of productivity, homelessness, disability. And certainly we know PTSD and suicidality are related, and certainly PTSD is also associated with comorbid substance use and a host of negative health symptoms. So the good news is we consider PTSD a treatable condition, and trauma-focused therapy is going to give you the best chance of recovery. And for many people, this can mean completely eradicating their symptoms. For others, it can reduce the intensity or the disruption of the symptoms. And we see here in this slide that our 5 clinical practice guidelines all have trauma-focused therapies as the #1 recommended first-line treatment, specifically things like cognitive processing theory, prolonged exposure, and EMDR, which of course are broadly CBT. And this, just to set the frame again, in terms of what we know about treating PTSD from the perspective of mechanisms, our evidence-based first-line treatments are incredibly grounded in research and theory, that is cognitive behavioral mechanisms, and includes things like emotional processing theory, fear extinction, and cognitive processing. Weaved through all of these is this kind of expectation that we, in the process of doing trauma-focused therapy, we pull up the trauma. If it's emotional processing, we're going to pull up fear structure, and we're going to be looking at the fear response and the meanings associated with it. With extinction, we're going to gradually expose someone to the feared response in the absence of the negative consequence, with the hopes that they will unlearn the associated fear response. And then, of course, with cognitive processing, which is really grounded in social cognitive theory and emotional processing theory, we are looking at the meaning making that is around the trauma, and how, if erroneous meaning making, can really disrupt recovery and stall the process of healing from trauma. And why this is important, and why I'm kind of framing these mechanisms, is because a lot of these mechanisms that are embedded in our frontline treatments require that we kind of process and face the trauma. And that is a hard ask for a lot of individuals with PTSD. And because of that, there's reasons that folks don't engage with treatment, they don't access treatment, or they may prematurely drop out of treatment. And so really kind of being mindful that we know these therapies work, we know these mechanisms are effective, and yet we still do struggle with folks sticking with and benefiting from our treatments. Just to say a few words about medication, we know that the evidence supports that psychotherapy is going to be your first choice. If that is not of interest, there's also medications. We have 2 pharmacological options for PTSD with 2 SSRIs, sertraline and paroxetine, both of which have FDA approval. But it is important to note that despite psychotherapies and medication, I think we're at a stage where many of us would agree that there's room for improvement across the board. When we're thinking about our pharmacotherapies, we really haven't had any new FDA-approved medications for PTSD since 2001. And when we're thinking about our psychotherapies, they're promising, and people do benefit, but maybe people don't always benefit enough. They don't fully recover, they drop out. And so this idea is, are there alternative pharmacological or psychological ways that we could be thinking about treating PTSD? And that's really where this idea of psychedelics, this kind of novel model of care, like why psychedelics, why now? Psychedelics are increasingly being looked at as a way to increase effectiveness of our treatments. It's a very different paradigm. So many of our traditional psychiatric medications might reduce symptoms or might kind of blunt the symptoms. With psychedelics, we're actually looking to enhance the connections and potentially allow for more emotional processing. We want the emotions to come up. In many ways, this mechanism could be a catalyst for many of our mechanisms in our evidence-based treatments for PTSD. So really this idea of how can psychedelics allow us to tolerate difficult trauma content and emotions, and perhaps allow the individual to process a wider range of emotions, and really to kind of lean in to the trauma processing rather than, kind of turning away or avoiding. And Dr. Michael Mithoever, who is one of the pioneers with MDMA assisted therapy, often will say psychedelics are not about feeling better, but about getting better at feeling. And so really this idea of like, we want you to, be able to sit and feel the feelings that otherwise are maybe being pushed away. So, and for many of us doing trauma-focused work, when we think about psychedelics and we think about trauma-focused work, a lot of us struggle with getting our patients to get to that deeper trauma-like processing. One of my colleagues, Dr. Perry Villiotis, will say it's like chiseling through concrete to get some of these folks to do the deeper work. And this question of if we involve psychedelics with our current models, could we potentially accelerate some of what we've been doing with our therapies for the last several decades? Can we potentially move the needle with regards to treating PTSD, but also potentially beyond PTSD? Can we get better, kind of movement with well-being and growth and relationships, and some of these things that we haven't necessarily always been able to address with some of our treatments? So very quickly, what are psychedelics? The word psychedelic comes from two ancient Greek words, psyche meaning soul, delic meaning to reveal. So this idea of kind of going into the mind and revealing things that we wouldn't otherwise see. Humphrey Osmond referred to this as like mind manifesting. There's a range of psychedelics that are considered both chemical and natural compounds, often referred to as classic versus non-classic. The classic psychedelics are what people often refer to as psychedelics, things like LSD, psilocybin, ayahuasca. And they often include that kind of classic hallucinogenic experience, which is usually exerted through the activation of the serotonin 5-HT2A receptor. The non-classics, which I'll be talking a lot about today with MDMA, is often the purists might even say it's not a classic, it's not a psychedelic per se, but it is still considered a psychedelic, but often referred to as a non-classic or an entactogen or an empathogen. And then, of course, ketamine, which folks are maybe aware of because it is currently FDA approved for the treatment of treatment-resistant depression. Just to give you a flavor, I like this image. It's in a paper by Wolfgang Hogue in 2023. It's a spider plot, which really shows you here on the different axes that the farther you get from the center, the more profound the dimension is being endorsed. And I think it's a nice way for you to take a look at how dramatically different and how variable a psychedelic experience can be. And the experience can depend on the actual compound, what is the psychedelic, the individual, the dose, the environment with which it's being used. But you can see here with the classic psychedelics like psilocybin and LSD, you're going to get a lot more of those kind of hallucinogenic imagery and audiovisual synthesis, complex imagery. In contrast, when you're looking at MDMA, it's definitely doesn't necessarily have that classic hallucinogenic experience. And why that's important is that when patients are coming in, they often will lump all of these psychedelics into the same category and have a lot of kinds of expectations about what they're going to experience, even though we know there's so much variability in this experience. One of the things I think is incredibly important is this idea of the duration of the effects, both the acute effects and some really exciting research that's coming out about the after effects. So this slide really shows, again, the acute effects when someone is, profoundly experiencing the psychedelic. And you can see here that ketamine is kind of the briefer 30 minutes to 2 hours, with ibogaine being 36 to 72 hours. Thinking about, psychedelic-assisted therapy used for kind of medicinal purposes, you could do ketamine, psilocybin, MDMA, potentially in an office, outpatient, but something like LSD or ibogaine, you might need to do over a weekend. What has been really important, and this has not been shown in humans, but certainly in with some research with mice, is this period after the acute psychedelic experience. And I want to lay the foundation here because we're going to be thinking about what's the role of the psychotherapy. Guy Dolan, a neuroscientist at UC Berkeley, tested various psychedelics with mice and found that all these compounds had this kind of opening up, or this learning critical period after the psychedelic. And why this is important is with adults, typically a critical period is no longer open. And when we talk about like an open critical period, we're talking about a period where there's maybe some malleability for new learning. And this is really important information in terms of us thinking about how do we want to leverage psychedelic experiences therapeutically. When do we bring in the therapy? When do we do the psychedelic? And what is the heightened state of kind of neuroplasticity that someone might be experiencing? So if you look at the slide and you see, for example, psilocybin and MDMA, it's about 14 days after the acute experience of the medicine that you're still having this kind of potential period where there's squishiness or an opportunity for new learning, possibly neuroplasticity. A lot of reasons to think there's a lot happening that we could be leveraging with our therapies. The flip side of it is, I would say, this period after a psychedelic acute experience, while it's also potentially beneficial for therapy, I also think it's important to note that it's also a vulnerability. If someone is more fragile, we also want to be thoughtful about what kind of environment they're being exposed to after a psychedelic. Possible therapeutic mechanisms, a lot is unknown, so I'm not going to go too much into this, but I will say that some of what we do know is been shown in preclinical research, not as much in humans, although we're getting more and more research every day on this. Broadly, the neurobiological and neurochemical experiences that there's a lot happening with different neurotransmitters, but serotonin is certainly one of them, dopamine, GABA, glutamate. There's some reason to think, again, there's this neuroplasticity, this opening of learning periods. There's some report on disruption of the default network, which has to do also with kind of disrupting ruminative thinking. And then there's this kind of more phenomenological or psychological experience that's happening, and which I mentioned is this idea of having new perspectives, reduced fear response, having emotional breakthroughs, being able to kind of process trauma that you haven't been able to actually otherwise look at. And then, of course, relationally and spiritually, there's a lot of things that are also happening, but particularly with MDMA, which has a kind of a pro-social piece, we do see a lot of potential for relational connections. We often think of MDMA as kind of the heart medicine, where it really opens up your heart to other people, but also to yourself, and thinking a little bit about how that could be a catalyst for some of the work we're doing with trauma survivors. I will say just a brief history. Psychedelics have been around for thousands and thousands of years, certainly with indigenous societies, having the longest legacy and spiritual practices, such as psilocybin ceremonies in Mexico or ayahuasca in Peru. So certainly there's a long history of plant healing, plant medicine. It was in 1912 that MDMA was synthesized in a lab. Shortly thereafter, LSD. Again, both of these are synthesized in labs. And in the 40s, kind of effects of LSD were discovered. And this really led into this kind of first wave of psychedelic research and kind of this popularization of psychedelics. This is really where there was some interesting look at LSD and psychotherapy, and this individual Stan Grof had done some interesting work looking at kind of yoking transpersonal psychology with psychedelics, which you can still see some of the vestiges of that today. While this period was kind of a period of increased research, there was also increased kind of recreational use and eventually stricter regulatory controls, and eventually it was made to Schedule I drugs, and this really came at a halt of the research. Move forward, we are now, I think, after a gap of psychedelic research from the 70s to the early 2000s, we're having this kind of resurgence, or this renaissance, if you will, of psychedelic therapy. And particularly looking at how do we use psychedelic therapies with what we know today with some of our contemporary psychotherapies for treating a range of mental health conditions such as depression and PTSD being two that are on the forefront. So MAPS, which is the Multidisciplinary Association for Psychedelic Studies, was incredibly instrumental with moving what's called MDMA-assisted therapy forward for research. They've completed phase 3 studies, which we'll talk about in a moment. At the same time, psilocybin's also received a tremendous amount of headway with looking at psilocybin for depression, and they're also in their phase 3 studies right now for psilocybin. Going to quickly touch on psychedelic-assisted therapy just to make some distinctions, because psychedelic-assisted therapy is a very specific way that we're using the psychedelic with a therapeutic approach, not to be confused with recreational use, which has been also part of Western culture for a long time. Also not to be confused with what we would call psychedelics for wellness and personal growth, which has gotten very popular recently and is actually legal in some states like Oregon and Colorado. This could include also microdosing. The wellness model and microdosing have not been well researched, so we don't necessarily know how beneficial it is. And then, of course, the longest standing history with psychedelics, of course, is this history with plant medicine with indigenous societies. What we're talking about here, though, is the intentional psychotherapeutic use of psychedelics to facilitate, typically by a clinician, a therapeutic intervention. And the psychedelic is used before, sometimes during, and after the kind of the process. And it's really this idea of a synergistic process. And when we're talking about psychedelic assisted therapy, I don't want to oversimplify it, but there's really three kind of models that have emerged. One is this idea of psychological support, where, for example, with the Compass psilocybin trials, you'll see that the psychological support is in the preparation phase and after the medicine phase. And really the theory is that the psychedelic is the method of action and that therapy is kind of wrapped around the psychedelic to keep the person safe. That is different from the MAPS model or the Lycos approach, which is really actually taking a more formal psychotherapy and yoking it with MDMA for a very synergistic kind of combination between the therapy and the psychedelic. And then the last model, which I'm going to talk about, and which Anne and Barbara Rothwell will talk more about, is this idea of a synergistic, but almost like an augmentation or a catalyst model, where we're going to yoke a psychedelic to really catalyze some of the CBT mechanisms for treating PTSD, for example, fear extinction or emotional processing with some of our current treatments. So why psychedelics for PTSD? I hope I've laid a foundation. Like right now is a great time. We're kind of wanting and needing novel treatment approaches. We're learning a lot about psychedelics. We know a lot about treating PTSD psychotherapeutically. And there may be some really exciting ways that psychedelics for PTSD at this moment in time could really help us kind of move that needle, so to speak. And again, thinking about what is required for our PTSD treatments to work, where do we struggle? How can psychedelics help us in that process? And so I'm going to talk just briefly about psilocybin, but I'll spend the bulk of the time talking about MDMA. So psilocybin is, again, a classic psychedelic. It's a naturally occurring tryptamine alkaloid found in many species of mushrooms. Again, it's been historically used in religious and spiritual contexts. It's predominantly, again, the 5-HT2A receptor agonist. Has, as I mentioned before, lots of kind of hallucinogenic reports in terms of sensory, visual experiences, loosening of kind of rigid thinking. It's often referred to as like dreaming while awake. And again, it's being researched for things like anorexia, OCD, with, of course, phase 3 studies underway currently. Again, I do want to mention that because of the role of the serotonin, we do, most of these studies actually require someone to be tapered off any kind of contraindicated medication. And I just want to say that because a lot of our folks who are struggling with PTSD and or depression may be also taking medication that usually has to be tapered before they can start a psychedelic. So with some of the mechanisms for PTSD and thinking about psilocybin, so psilocybin pharmacologically has been shown to reduce amygdala reactivity, has an ability to reduce the threat response, has some research showing increased functional connectivity, some increased neuroplasticity, and again, this disruption in the default mode network, which again translates into some of these psychological mechanisms that we have talked about in terms of cognitive flexibility, insight, ability to tolerate difficult emotions, and loosening of kind of these defense mechanisms that make it hard to do some of the trauma processing work. A lot of the excitement with psilocybin for PTSD has also certainly given interest to how can we look at psilocybin for psilocybin for depression. How can we look at using psilocybin for treating PTSD? And many of the studies with depression do have samples also that have had a history of trauma and also may have some PTSD. And so there's some studies that have shown decreased PTSD in these studies. There's only actually one study to date that has looked at psilocybin for treating PTSD, and this was presented at ISTSS. It was done with the Compass Group, and they actually did it was an open trial for PTSD with 22 outpatient patients who were coming in for PTSD. And again, this model with psilocybin is, again, using the psychological support. So it wasn't yoking it with a psychotherapy per se. And what they found was clinically meaningful reductions in the CAPS from baseline to 4 weeks, and it was sustained at 12 weeks. And then improvement in functional impairment also sustained at 4 and 12 weeks. They also reported treatment emergent adverse events. Common ones would be headaches, nausea, crying, and fatigue. And so, again, not a lot of research has been focused on psilocybin for PTSD, and I don't believe there's much research happening with psilocybin, yoking it with a psychotherapy, but certainly given mechanisms of psilocybin, there's a lot of kind of reason to think that this is going to be an important area of research moving forward. Shifting to MDMA, so by far we know the most about how MDMA for PTSD using psychedelic-assisted therapy, so MDMA-assisted therapy works. And again, MDMA is quite different than the classic psychedelics. It has a very unique pharmacological kind of presentation. MDMA is a triple reuptake inhibitor that produces kind of an anxiolytic and pro-social effects through neurotransmitters serotonin, dopamine. Unlike the other kind of psychedelics, this actually has a release of oxytocin, prolactin, which of course are the hormones that are associated with trust and bonding. These are the hormones that a mother might have after she gives birth. And there's also research showing reduced amygdala activity, which of course is the brain region associated with fear and trauma. The experience of MDMA is again referred to as the love drug. Not that necessarily you're going to have a positive experience, and of course the street name of MDMA is ecstasy. And if someone is using MDMA medicinally, they do have an openness, a sense of compassion. But they also do a lot of difficult work looking at things that they wouldn't otherwise be able to look at. And a lot of times the subjective effects of MDMA build kind of the trust and the comfort and that kind of needed, fear response that is reduced, that allows someone to lean in and really go through some emotional content that they haven't been able to otherwise process. Looking at things through a different perspective, and often one that has compassion for themselves and compassion for other people in their lives. And again, the mechanisms line up. Again, these are theoretical mechanisms. We need a lot more research, but reduced fear response, increased hippocampal activity, reduced amygdala reactivity are some of the neuropharmacological things that are happening. Again, the psychological are really going to be the sense of trust and safety that are going to really help lubricate the process for doing trauma work with PTSD. So what do we know? I want to just talk a little bit about the state of the science and really focusing on MDMA and really focusing on the model that has been researched the most to date. But then I'm going to talk about a few other models that are being researched as I wrap up this model. So Lykos Therapeutics, which often was referred to as MAPS, it started off as MAPS. Now MAPS is one part, but Lykos Therapeutics is another part. They developed this manual called MDMA-assisted psychotherapy, and they were really the pioneers of moving phase 2 and phase 3 studies forward to show the benefits of MDMA-assisted therapy for PTSD. And you can see a picture here of two of the trainers and kind of an example where you have 2 therapists and a patient lying down, and there's headphones and there's eye masks and a very comfortable environment, which I'll talk about, which is kind of the model that this Lykos Therapeutics has been testing. The model that's been tested actually kind of depicts the protocol. It shows both the prep sessions and the integration, which is really the therapy. There's 3 prep sessions, a full day of med sessions, and then 3 integrations. And that is what we'd call like one cycle of a psychedelic assisted therapy. And in their protocol, they have 3 kinds of cycles of this. Therapy is 90 minutes. They space out the medicine sessions by 21 days. There's typically 2 therapists involved. And a lot, again, this preparation and the integration is preparing for the medicine session, and integration is really the idea of working through therapeutically what has come up during the medicine session. And I'll say that during the medicine session, We use this going inward with eye masks, music, which kind of parallels the arc of the medicine. There's very much a mindfulness approach and also a somatic approach with the idea of how you might feel the trauma in your body. Really very relational, and the therapy is very non-directive, so very different than the therapy that maybe we're doing today with CBT. Their inner directed therapy is really this idea that you're going to trust the inner healer and a person's innate capacity to heal their trauma wounds. Kind of influenced by internal family systems, sensory motor psychotherapy, and transpersonal psychotherapy. And one thing I want to say is during the medicine session, really you're just there to support, the two therapists are there to support the patient, but we're really not actively doing any kind of therapy or processing. We're really allowing the person to go inward and share what's coming up for them. What do we know? Like I said, there's been several phase 2 studies that were pooled with 103 participants. I'll highlight here the phase 3 studies. There's two randomized placebo-controlled phase 3 studies that were actually presented to FDA, and both of them are in Nature magazine. I want to say that both of these studies, very rigorous inclusion and exclusion criteria to get into these studies. I won't go in depth into that, but just so you know that one question is, who is this a good fit for, when we have a lot of folks that do get excluded. And what they found in this first trial, Mitchell 2021, was that the mean change scores in the CAPS-5 was 24.2, and in the control arm was 13.9. And again, this was a placebo control arm that had the therapy only compared to the MDMA therapy. It's important to note here that the MDMA-assisted therapy certainly was superior to the placebo arm, but actually both of them had significant improvement when we think about 10 to 12 points being, kind of the bar we use for clinical significant change. More recently, 2023, their second phase 3 study came out, and to highlight here in the second trial, Mitchell 2023, in red here you see the MDMA, and in blue the therapy only. And what you find here is that the CAPS change for the MDMA was 23 points, and for the therapy only was 14. So again, the therapy with MDMA was superior to the placebo therapy alone. Again, both were actually considered quite significant. In the MDMA, there was 87% that were considered clinically significantly improved versus 66 in the therapy alone. So I want to just say that there's a lot of questions about this in terms of the science, and there's definitely a lot of promise and a lot of signal. And I think that ultimately when it was presented to the FDA did not approve it and is asking for more research, which has really been informing this kind of next phase of studies that are underway. One of the challenges with the phase 3 studies and with many of the psychedelic studies is this idea of blinding and treatment expectancy. And I always say with the subjective effects of a psychedelic, it makes blinding incredibly hard for participants. Certainly, really across all psychedelics, but the more classic psychedelics in particular. When you can't adequately mask, then you, of course, have concerns about people knowing what arm they're in, and then you have concerns about the placebo effect. So to give you an example, in these phase 3 studies, the majority of the people and the participants who received the MDMA correctly guessed that they were in the MDMA arm, and the majority that received the placebo also correctly guessed that they were in the placebo arm. So this, of course, raises the concern about how much of the signal that we're seeing is about placebo and how much of it is about kind of the unique synergy between the MDMA and the therapy. The challenge then becomes, in addition to having unmasking in these trials, you also have this challenge of a lot of expectation and what we have referred to as kind of the psychedelic hype, where there's a lot of media coverage and a lot of very persuasive kind of portrayals in the media about the power of psychedelics, and has kind of been referred to as a little bit of a hype bubble. And the worry about that is this expectation combined with unmasking, and what does that do with regards to treatment effects, placebo and nocebo effects. And so it's a very big challenge in our psychedelic research, one that we haven't necessarily solved. And it was a criticism of these phase 3 MDMA studies. Other criticisms, in addition to not having an active comparison group that was adequately masked was not really involving a psychotherapy that is considered one of our frontline evidence-based psychotherapies. And there's a lot of reasons for that. As I mentioned, a lot of our therapies that were developed for PTSD happened during the prohibition of psychedelics. There was also concerns about the feasibility of implementation. So as I mentioned, the model for Lycos is about 42 hours with 2 therapists and 3 8-hour medicine sessions. And it does raise concerns about accessibility and cost and how would we actually, kind of set this up in a way that could be implemented. And then there was concerns that some of the participants, about 40% of them, had actually previously taken MDMA, and that potentially might have also influenced the bias of the sample. So all of that to say, I think it set us up really for this idea of what is the new landscape for how do we move forward? We definitely think there's a signal there, there's promise, there's a lot of excitement. But how do we design these studies to kind of get at these questions of what is the best treatment? What is the best psychedelic? How much do we do? This new frontier of psychedelic assisted therapy, which is very exciting, is this idea of, do we want to be thinking about incorporating some of our cognitive behavioral therapeutic mechanisms for PTSD with psychedelics? And if we do, what are the best approaches to integrating the psychotherapy? What's the best approach to integrating the psychedelic? What's the best therapeutic mechanism that we're trying to accelerate? And again, a lot of excitement and a lot of unanswered questions and a lot of debate about the best approach. And so there is a lot of kind of debate out there about, how should we move forward and what would be helpful at this juncture. I want to just highlight this recent article's special edition that we just did looking at novel models of psychedelic assisted therapy. And then I'm going to kind of talk a little bit about 3 models that are being tested, which will kind of lay the ground for the next panel webinar that we're doing. But cognitive behavioral practice, this is a special edition on looking at MDMA for CBT. And I'm going to talk a little bit about a couples model, CPT, and PE, which are 3 treatments that we use quite frequently with PTSD. So one is this idea of cognitive behavioral conjoint therapy, which is a treatment that was developed to treat PTSD at the dyadic level. And in some ways makes a lot of sense because of the very strong relational component that MDMA brings to the table. And it's this idea of, can we leverage the relationship to help with the healing process? And particularly with MDMA, can we really accelerate these kinds of mechanisms of trust, emotional recognition, empathy, being able to disclose and communicate content? So folks in the field have been looking at CBCT, which was developed by Candace Swanson. It's a 15-session protocol. We more recently looked at it with an 8-session protocol. And what we're really looking at here is, again, this idea of how do we kind of really accelerate these mechanisms? And if we look here at the mechanics of this, looking at trust, emotion recognition, empathy, approaching communication, and approaching trauma. And just to give you a flavor of the protocol, this is the protocol that Ann Wagner and myself have tested, where you're actually having 2 med sessions that are sandwiched in between psychotherapy. So there's preparation, there's the med session, there's integration, and then there's more therapy, which is the CBT therapy. Then there's another med session, and then there's more CBT. And this is actually over the course of 6 weeks. It's not masked, but it is condensed. And so you're doing prep and introducing the CBCT model, the med session, integration, and then 2 CBCT sessions the week after, and then CBCT for the following 2 weeks, and then another med session. So it's a very scalable outpatient model. And Candace Monson and Ann Wagner did test this, and they actually dosed both partners and found that it was quite effective for reducing the PTSD and for improving relationship satisfaction and happiness, and reducing things like depression and sleep. Again, it's an open label. It wasn't a randomized control study, and both partners got dosed. They have a study underway, Ann Wagner does, which she'll be able to talk about in the next couple of weeks at the panel. And they're actually doing a crossover design where they are comparing it with and without MDMA and then doing a crossover design. And then we recently just finished a trial here in the VA, and this is a case paper in our special series where we actually only dosed the veteran, and we used the 8-session model. So the idea is keeping an eye on scalability. And so if people are interested, they could take a look at this paper. This is with a veteran population. I want to just talk about CPT. Again, a lot of potential mechanisms here. We could be thinking about that MDMA could help with the cognitive flexibility, allow for new learning, a really nice way to yoke MDMA with the mechanisms of CPT. This is a model that Anne Wagner is doing with 2 med sessions, again, embedded within the CPT protocol. She has some interesting data with a sample of 10, which she can talk a little bit more about in the next webinar. But what she did find, and this is hot off the press, is that she did find with the sample of 10, again, it's an open trial, so no comparator, that there was a nice robust effect size of 0.9. And last but not least, MDMA and PE, which is very exciting, is this idea that PE uses fear extinction. And there's been some really fascinating work coming out of the Emory lab looking at how MDMA with both a healthy sample and with rodents can really accelerate fear extinction. So it makes a lot of sense that we would actually do this with PE. This is their protocol if you're interested. And they are actually using the masked PE model, and they're flying folks out to Emory, and they're really leveraging that kind of 14-day window of kind of potential neuroplasticity that might be happening. And they're actually front loading it with 1 med session, so really scalable, where they're doing the med session at the very beginning of the PE to accelerate the fear extinction, followed by masked prolonged exposure over the course of 14 days. What is really exciting about what they're doing is they're actually doing 2 imaginal sessions during the med session. And they've also kind of talked about this idea of touch in a way that I feel like is going to be a little bit more palatable for many of our current clinicians. And they have a really cool case report also in this special series if you want to take a look at their protocol and their model. One of the things I would say is all of us are being thoughtful about scalability, and the Lycos model is in some ways wonderful and helpful and potentially a heavy lift to take to scale. So a lot of us are thinking about how can we do this outpatient? Do we need 2 therapists? And this just gives you an example of the Emory model versus the Lycos model in terms of scalability. Very exciting. There's 2 DoD funded studies that are underway. One with Strong Star looking at this model of 100 milligrams to accelerate MDMA compared to a low dose arm. And Emory is looking at, Jessica Maples and Barbara Rothbaum's group is looking at it with veterans and civilians. Both of these were just funded or just getting off the ground. So a lot of exciting research that's going to be happening. And before I kind of wrap up, I want to say that it's not without a lot of clinical and ethical considerations. And I say this as a clinician who's done a lot of these med sessions and has worked a lot with trauma and PTSD. There's a lot of excitement, there's a lot of enthusiasm. We also want to be very careful about having standards of care when we're talking about working with people in altered states and being thoughtful about how vulnerable someone is when they're in an altered state. The idea about professional boundaries when someone's in an altered state is one that should not be kind of underemphasized. I think the managing of expectations, both clinically and research, has been very, very challenging to work with. We want to move forward with optimism, but also skepticism. We want to have kind of what I would call an equipoised approach. We really need the science to be there to support the enthusiasm. And I would say that, there's a lot of discussion of like hype and hope. And I also want to add that there's a lot of desperation, and it's not always a good combination when we still need more science for people to come in thinking that this is going to solve all their problems. And so really trying to be thoughtful about managing expectations about what we can say, what we know, and also what we don't know. And it doesn't mean that we're not really enthusiastic and excited, and we still need a lot more research. Also, risk and adverse events. It's not without its risk and adverse events. I mentioned the taper. There's also some implications for cardiovascular risk, particularly with MDMA and to some extent with psilocybin. So everything is going to be a balance of risk and benefit. Is the risk of reducing someone's SSRI worth the benefit of a psychedelic assisted therapy? And I think this is a really important piece that I want us to be kind of thoughtful as we move forward. And then, of course, being mindful of the long legacy of indigenous kind of plant-based care that is behind a lot of these psychedelics, and how do we kind of maybe run parallel to that, but not necessarily interfere with that, and in many ways pay homage to it, really. Future research, so much exciting work that still needs to be done, rigorous designs, masking, and active comparators. I don't think we have a solution, but we are working really hard to find good ways to actually get a good masking for both therapists and patients. Having a very equipoised approach, kind of going at this neutrally, as we do with most of our research. A lot of research we need to know about mechanisms, like, we have the phenomenological, the psychological experience of what's happening, but can we get some objective mechanisms that also can corroborate that and can really help support what we might be seeing in the room subjectively? Can we also look at it objectively in terms of mechanisms? So what are the best therapies? How much medicine? What medicine? When do we do the medicine? What are scalable models? Who's the best candidate? Amazing questions out there that I think a lot of interested people hopefully will continue to do the really important work that I think has, MAPS and all these folks have really been able to take it very far, and want to kind of continue doing this work. I do want to wrap up with a couple of quotes, not from patients, but from providers. As someone who's worked with providers for several decades, I often say our care is only as healthy as our workforce. And, this is heavy work we're doing with trauma patients. And I think as much as we want patients to get better, we also want providers to feel like what they're doing is effective. And so a couple quotes here from therapist one: I was originally intimidated by MDMA-assisted therapy, but I found it to be liberating and relative to our traditional therapies. This particular person says, I don't want to go back to doing traditional therapy. Another therapist said, this treatment feels so powerful. I feel energized at the end of an 8-hour medicine day. The changes I see in my patients are palpable and meaningful. And why I wanted to end with this is that, we want to have good care for patients. We also want to keep our workforce vital. We want to be mindful of burnout. We want to be thoughtful about, are there ways that psychedelic treatments can also help providers also feel energized and more effective with some of our most difficult to treat kind of populations. So I'm going to stop there. That was a fast run through because I know we started about 10 minutes late, so I apologize for starting late. Hopefully, if you have lots of good questions, not next Tuesday, but the following Tuesday, which is the 24th, you can field those questions with a live panel discussion with myself and Ann Wagner and Barbara Rothbaum. And so this is really just a primer for that.
Thank you so much, Dr. Morland, for a fantastic presentation. And thank you all for being here with us today and also dropping such thoughtful questions in the chat. We will have those on record, and they'll inform the part 2. So thanks, everyone, and have a great rest of your day.